We'll introduce the first paper.
Our first paper comes from the University of Florida. It's entitled Decreasing Morbidity and Mortality in 100 Consecutive Esophagectomies. Doctors Ben David, Sarosi, Sendan, Howard, Rosides, Hochwald. Dr. Ben David.
Thank you for the panel for having me. I'm Dr. Ben David. I'm going to get started. Here are my disclosures. Esophageal cancer is a worldwide disease affecting 11 million patients. The incidence of esophageal cancer in the United States is increasing dramatically. Annually, it's estimated that about 16,000 Americans are diagnosed with esophageal cancer and about 14,500 die from this disease. However, the outcomes have significantly improved. At our institution, we often use an endoscopic ultrasound to provide us with the T stages. We also use a PET and a CT scan for regional metastatic disease. The minimally invasive esophagectomy was first described by DePaula and later by Swanstrom. Lukatic then later modified it to include the thoracoscopic esophageal mobilization. He also reported about the mortality, respiratory complication, and blood loss. There are many approaches to minimally invasive esophagectomy as listed up here, and I think what's best is what best works for you. Our esophagectomy experience at the University of Florida includes 105 patients from August of 2007 to January 2011. We're doing them at two institutions at the University of Florida and the VA hospital. You can see the numbers. 5 patients were unresectable. They had advanced T4 disease. They were all squamous cell. 89 were males and 16 were females. Our initial experience was started at the VA. As you can see, here's our demographics. 15 of our patients had adenocarcinoma, and 94% of our patients were smokers initially. Our initial esophagectomy experience included 6 laparoscopic mini thoracotomy ivory loss as a hybrid procedure. We then transitioned to a thoracoscopic esophageal mobilization, later laparoscopic gastric conduit formation in the left cervical anastomosis. In 3 of our patients, we required to do a linear side-to-side anastomosis in the chest. Here's our breakdown of our overall esophageal experience. 85 patients at the University of Florida, 15 at the VA. Again, majority of our patients have a thoracoscopic esophageal mobilization followed by a laparoscopic gastric conduit and a left cervical anastomosis. The mean age for our patients is 64. 5 patients were over the age of 80. The cancer type was predominantly adenocarcinoma. 5 patients were unresectable, as I previously stated. We also did this for 5 of our patients with benign disease. 4 of them had significant megaesophagus with sigmoid esophagus and 1 sclerosing of the esophagus. We're firm believers of neoadjuvant chemoradiation therapy, so about 70% of our patients did receive neoadjuvant chemoradiation, and our rule of thumb is anybody that has a T2 or N positive lymph nodes would get neoadjuvant chemoradiation. So we were able to complete 98% of our esophagectomies, minimally invasive and a hybrid procedure. 2 of our patients did require colonic interpositions. We had negative margins in 94 out of 95 of our cancer patients. 1 did have Barrett's dysplasia. Our lymph nodes harvest, our mean is 15, range from 8 to 31. These includes the patients that did undergo neoadjuvant chemoradiation. Our average blood loss is approximately 138 mLs. The length of stay is 7.5 days as compared to our open era the 2 years before, which was about 14 days. Our complications included an anastomotic leak of 4%. We had a gastric conduit leak, which was maintained by an endoscopic stent. We had 1 death from a saddle pulmonary embolus. However, our pneumonia rates and our pleural effusion were still high at 9% and 8% respectively. Our experience includes thoracoscopic mobilization of the esophagus and the left lateral decubitus. We do take the azygos vein. We mobilize the entire esophagus thoracoscopically. We perform then the gastric conduit laparoscopically. And we make our anastomosis in the cervical neck. That's the majority of our patients. We do a linear side-to-side 6 centimeter anastomosis. We've concluded from our experience that these are our favorable outcomes include operative blood loss, possible reduced mortality, more rapid return to good quality of life, better vision of the operative field, and then lower leak rates. We had similar lymph node harvest to our open. Our unfavorable outcomes includes the pneumonia rates are still high, about 9 to 10%. And obviously when you first start, there's longer operating room times. What we looked at more specifically is looking at the 2 years prior during our open era and compared it to our new minimally invasive the last 2 years. And we've shown that our volume has tremendously increased. When you look at the UHC data, we're 35 out of 100 institutions that participate in this. and our mortality rate is 1 out of 91, which there are 46 other institutions in the same category. So in conclusion, minimally invasive esophagectomy is an operation of choice at our institution for malignancy of the esophagus and benign esophageal tumor. However, advanced laparoscopic techniques and and experience with esophageal surgery is recommended. I'd like to thank the panel for allowing me to present our work.
Any comments or questions?
Thank you, Stefanos Dubrow from Calgary. 3 questions for you. One is, what's the stenosis rate in the neck? Do you do a Coker maneuver, and do you do a myotomy?
So I'll thank you for those questions. The first questions are, stricture rate is 4%. We've had 4% of our patients did have a stricture rate. Those patients that leaked, all of them had a stricture rate. We do cocerize the duodenum. We fully cocerize the duodenum. We take the right gastric vessel, the left gastric, and do significant lymphadenectomy, a D2 dissection. And with regards to a pyloroplasty, we do not do a pyloroplasty. We actually prefer to do Botox injection. The last 30 patients have got Botox injection. Our preliminary data shows that or a subset of our patients that had Botox had better gastric emptying study, which will be a subset of analysis later to be presented at a later time. But we do not do a pyloroplasty in our patients.
Over here.
Christy Dunes from Portland. I just want to congratulate you on your data. It's great. And I have a question about your very low leak rate at 4%. How do you define a leak?
So we do not formally swallow our patient radiographically. We do a bedside test with grapefruit at post-op day number 5. Okay. Anybody that, and we leave a drain in all of our cervical anastomoses. Anybody that obviously has any drainage output or any evidence of wound infection, which will then follow up with a formal radiology study, then we will, those are determined to be leak rates. So although we don't formally study every single one of our patients, we do bedside swallow studies.
Over here.
Joe Dodd from Missouri. Have you had any issues with chylothorax in your series? And then the other thing I've noticed in my own patients is that when you don't have an open procedure, you don't get as many adhesions. And I've seen 2 or 3 late paraesophageal hernias with colon going up in the mediastinum or alongside your conduit, which gets to be a significant management problem. Are you doing anything to prevent that, such as putting Surgisys or anything like that?
So I'll answer your first question first. We did have 3 chylothorax leak, all of which had to be taken back to the operating room to actually fix with ligation of the thoracic duct. With regards to paraesophageal hernia, 3% of our patients did have a significant paraesophageal hernia with the colon migrating up into the chest. What we've done recently is we've sutured the gastric conduit to the crura, trying to prevent any potential space, or if there's a big crural space, we would try to close that, but not strict on the gastric conduit. The patients that did present with a paraesophageal hernia, when we did take them back to the operating room, we did use Surgisys in order to repair the paraesophageal hernia defect.
Zaman Khan from Hayes, Kansas. Got a quick question. Look at the perfusion of your gastric tube. Do you do anything like a SPY or anything, or?
No, we do not. We oftentimes do not precondition the stomach. The gastric conduit is heavily relied on the right gastroepiploic. Obviously, in patients that we don't think that the stomach will reach up to for a cervical anastomosis, we will perform a thoracoscopic anastomosis in a similar fashion, side-to-side linear stapled anastomosis.
Dr. Ben-David, thank you very much. We got to keep moving on. Any questions that we don't get to, if the speakers could hang out in the back for just a few minutes so that we make sure we get all the questions answered, we really appreciate it, because we got a lot of great information here.